Tobacco use is the leading cause of preventable death in the U.S. Millions of Americans smoke or use tobacco products and are exposed to secondhand smoke, which leads to billions of dollars in health spending every year. Since 1965, nationwide smoking prevalence has declined by 50%. However, this progress is not evenly distributed, and disparities still exist for racial and ethnic minorities and low socioeconomic populations. Using the iceberg model, we examine smoking inequities while considering underlying structures and mental models. We determined that an imbalance of resources and power, as well as discrimination and marginalization, contribute to these disparities. Additionally, there are two mental models that drive tobacco control, which we'll outline on the next slide. These two conventional approaches are high-risk approaches, which focus on changing individual behavior of those at highest risk through targeted education or counseling, and population approaches that aim to change smoking norms by altering the environment through policy change. Rooted in these approaches, we created a conventional map of smoking that includes individual factors in green and environmental factors in blue. A plus sign indicates that variables move in the same direction, and a minus sign indicates they move in opposite directions. For example, while stress increases the likelihood of smoking, access to cessation services decreases it. However, conventional interventions may unintentionally amplify benefits for certain groups while minimizing them for others, which can sustain or widen disparities. In order to eliminate them, a priority population approach that centers on equity and addresses underlying structures from our iceberg model is necessary. We created an updated systems map that incorporates root causes of smoking or disparity factors in red. This new map can demonstrate, for example, how low-wage work is related to insurance coverage, which precedes access to cessation services. Other factors we identified include marginalization, discrimination, and social capital, which may not be considered when using conventional approaches.
We used our updated systems map as well as an impact gaps canvas to evaluate the potential of tobacco control policies to reduce disparities in smoking. One example we considered is smoke-free public housing. In this case, the challenge was that 15% of US adults, but 1/3 of public housing residents smoke. To address this issue, in 2018, all US public housing units were required to go smoke-free. This had some success, with residents self-reporting higher quit rates, but half of residents violated the policy. Thus, the root causes of higher smoking among public housing residents, such as housing instability and related stress, remain unaddressed. Our updated map visualizes the intended mechanisms of change for addressing smoking disparities and the unintended impacts of smoke-free public housing. Starting with the mechanisms of change on the left, the policy is expected to reduce the number of homes that permit smoking, which then lowers tobacco use among family and friends. This reduces the normalization of smoking and perceptions of tobacco use as low risk, and these processes are reinforcing. However, the right side of this slide shows that housing instability is increased when residents violate this policy. This increases financial strain and stress and reduces feelings of control. So this policy has the unintended consequence of increasing smoking and leaving low-income residents at further risk of housing instability. The traditional stakeholders involved in tobacco control efforts include the government, health systems, tobacco control advocacy groups, and academic researchers. Given the unintended effects of the policies that we assessed, we used our map to understand whose perspectives are still needed to address the root causes of smoking. Examples include mental health practitioners who can assist with stress management, and importantly, smokers themselves who have not traditionally been engaged. To gather feedback on our model, we conducted semi-structured interviews with 7 traditional and non-traditional stakeholders. Overall, the interviewees validated the constructs included in our model and provided insight into new relationships that we had not previously included. By applying both a system science approach as well as a health equity lens to our problem, we found that disproportionately high smoking rates in priority populations are a product of traditional smoking risk factors, as well as unequal power and resources. Our updated conceptual model revealed that even policies designed to promote equity and tobacco control can have unintended consequences. The perspectives of a broader range of stakeholders are needed to ensure equitable outcomes. Finally, we learned it is important to use an iterative process for refining systems maps to identify new relationships between variables, as well as other stakeholders to bring to the table. Thank you.